Hello, and thank you for joining this OncLive peer exchange titled Navigating New Treatment Options for Hepatocellular Carcinoma. We're experiencing a sea change in terms of systemic therapy for advanced hepatocellular carcinoma. In 2019, we had several new options requiring us to make decisions for both newly diagnosed and relapsed disease. In addition, we are refining the use of liver-directed therapies in early-stage HCC. In this OncLive peer exchange panel discussion, we're going to discuss the latest information surrounding the management of advanced liver cancer. We'll take a detailed look at new opportunities for treatment to provide you with practical perspective on optimal treatment for your patients with HCC. Today, I'm joined by a group of my colleagues who are renowned experts in the field of hepatocellular carcinoma research. We'll discuss the evolving research presented at the 2019 ASCO GI annual meeting surrounding the treatment of newly diagnosed and relapsed disease, as well as discuss liver-directed therapies for early-stage HCC and the management of advanced-stage disease. I'm Ghassan Abu Alfa, medical oncologist at Memorial Sloan Kettering Cancer Center. I'm professor of medicine at Weill Medical College at Cornell University, New York. Participating today on our distinguished panels are Dr. Richard Fenn, professor of medicine in the Department of Medicine, Division of Hematology and Oncology at the Geffen School of Medicine at UCLA in Los Angeles, California. Dr. Katie Kelly, associate professor of clinical medicine in the Division of Hematology and Oncology at the University of California, San Francisco. And Dr. Andrew Zhu, professor of medicine at the Harvard Medical School and director of the Liver Cancer Research and Medicine at Massachusetts General Hospital in Boston, Massachusetts. Thank you so much for joining us. Let's begin. So Richard, as we saw in the introduction, and admittedly it has been an incredible 2 years in regard to liver cancer, but it will be nice to kind of like go back to the basics first and really to kind of like take it from there. And at the moment, one of the key elements that, all of us are seeing in clinic, patients coming and asking about their genetic profile of their tumor. What does that mean for HCC?
Yeah, so liver cancer, I think, has been the orphan of solid tumor oncology in that in many ways, the interventions that are making a difference have generally come to liver cancer as an afterthought. And that is not limited to just therapeutics, but also our approach. Still, we approach liver cancer as a one-size-fits-all approach. We don't differentiate based on molecular makeup, though there's been a lot of molecular studies done. There's been excellent studies from the NCI and other groups, as well as a large TCGA, just like there's a TCGA in every other solid tumor, there's one in liver cancer. And one of the challenges in liver cancer is that we don't have a lot of mutations that we have drugs for. So there's the challenge of identifying an alteration and saying that we can drug that alteration, and then the other thing is linking that alteration to therapeutic benefit. And right now, as we sit here today, we don't have really a good linkage between molecular diagnostics, like Foundation Medicine, for example, next-generation sequencing, leading us to any therapeutic. The one exception to that, in all honesty, is something like MSI status, right? If you found a tumor that's MSI, there is a tumor-agnostic approval for PD-1 inhibitors in that setting, but that alteration is very rare in liver cancer.
Fair enough. Actually, I've got to go back to the story of the checkpoint inhibitors and the genetics. But before we go there, by the way, and to agree with what you said, at this GI ASCO, we saw there was an abstract, if I recall, by Dr. Wheeler in regard to the landscape of the germline. However, this really probably doesn't apply directly to what we're talking about, to hepatobiliary. And there was, in other words, some patients with HCC and others a biliary tumor, presumably cholangiocarcinoma. And you're right, I would say that the data is not yet giving us one guidance or the other. Fair enough. Along that line, Katie, one of the classic arguments that we hear from our colleagues is you don't need a biopsy to get a diagnosis of HCC. And ironically, when we hear what Rich said, why do we need a biopsy?
I think the increasingly now that we have multiple treatment options both for HCC and for cholangiocarcinoma, it becomes incumbent upon us before starting a systemic therapy to make sure we're certain about the radiographic diagnosis, more so than when these cancers were so difficult to treat with limited options. And so I think increasingly, at least in our institution and what I'm seeing in colleagues, is that before starting systemic therapy, we're pursuing histologic confirmation in most cases, particularly cases who have equivocal imaging findings, which is not uncommon. So in patients who have an infiltrative tumor without great enhancement in all parts of the tumor, sometimes those can be a mixed HCC or cholangio or a frank cholangiocarcinoma or a surprising histology we weren't expecting. And so I think the top priority is making sure we know the right histology before embarking on systemic therapy, and to be very rigorous about the cases for which we employ a radiographic diagnosis.